Welcome everyone for the second class of our first batch. So today the topic for discussion is FDA approved orthobiologics and Indian regulation by Dr. Ravi. He's from Trichy. He's the director of Mother Cell Regeneration Center, Trichy, and he's an orthopedic surgeon from past 15 to 20 years. He's mainly focusing only on regenerative orthopedics and regenerative medicine. His main interest is PRP bone marrow SVF, and he do lots of bone marrow on day-to-day basis. And he was the first Indian surgeon to use allogenic stem cell therapy for osteoarthritis when it was launched by Government of India. That stem one product was used first by Professor Ravi in Trichy, and he's a dynamic orthopedic surgeon with guiding various orthopods as well as other regenerative specialists over globe. He's having a separate WhatsApp group for lot of discussions on regenerative medicine, not alone regenerative orthopedics. And currently, he is guiding 3 to 5 fellows in regenerative medicine PhD as well. So now I'm welcoming sir for the session on FDA approved orthobiologics and Indian regulations. Over to you, sir.
Yeah, okay. So welcome to all the uh, people who have joined this course on regenerative medicine. This is a new specialty, and Madan is coming from Stanley, which is one of the pioneer institute in India, where there is a department of regenerative medicine. So today in India, there is one medical college where there is a department of regenerative medicine, and that is in Stanley. And Dr. Sekunda is the faculty in that department. So they have got a very big lab. So you should know about the pioneers. I will be talking about some of the pioneers. But before that, who should listen to this? Why should somebody listen to this talk? If you are a young doctor, most of you are young doctors, you will need this for your practice. If you are an old doctor, you will need it for your own health and your own family members' health, because a lot of old geriatric problems are going to be addressed by this stem cell therapy. So a lot of scientists are also into this field. So for the scientists also, it holds the same. So stem cell therapy, is it approved in India or not? So many people still think it is not approved. But the fact is, stem cell therapy is approved since 2017. Now it is almost 8 years since the first approval for stem cell therapy came. So, and these are some of the pioneers. As I said, you can see 3 people from Stanley, 4 people. In fact, yeah, Dr. Surendran was the chief who started the stem cell lab, which was initially run for the first 10 years by Dr. Rosie Venula. And subsequently now Dr. Sekunda is running the stem cell lab for liver disease at Stanley Medical College. Both Dr. Rajkumar, who is a vascular surgeon, who was the first to do stem cell therapy for CLI as a principal investigator. So he was also at Stanley, and Dr. Namita Rajkumar, she also a Stanley student who became the HOD and the director of Egmore Eye Hospital, where they did limbal stem cell therapy. So some of these, you see some green tick, yellow tick, and red tick. So green ticks are all the stem cell research which has now become translated into drugs. So for example, Dr. Rajkumar, you can see green tick. That is because whatever he did for CLI using stem cells, allogenic stem cells, that clinical trial was subsequently approved by the DCGI. And today, all of us have got a product called Regina SIP for CLI. It is allogenic bone marrow derived stem cells, which is available for every Indian vascular surgeon or any Indian doctor treating ulcers, diabetic ulcers. Similarly, Dr. Namita Rajkumar, their limbal stem cell therapy is approved in India for corneal blindness. And Dr. Sujata Mohanty, again, she is the chief of the stem cell lab at Delhi. And again, they had worked on both the limbal stem cells, as well as they were also one of the multi-centers for vascular CLI, stem cell for CLI. And the yellow ticks are all for the trials which are ongoing. So in the Chennai, this Stanley, they have got the approval for phase 1 clinical trial using stem cells for chronic liver diseases. So once they start the phase 1, within for probably 3-4 years, they will be completing all the phases, and then we will be getting a stem cell product to treat liver failure. And the day when we get stem cell therapy for liver disease, it will be because of the hard work done by these veterans at Stanley Medical College. Dr. Vineet Ahuja from Delhi, he is doing the phase 2 trial for stem cell therapy in Crohn's disease with multiple fistula in ano, recurrent fistula in ano. So that is in phase 2. And Dr. Colonel Pawan Kumar Gupta is the scientist and as well as the clinician at Stemputics, who is responsible for all the products which have come out. Dr. K.M. Cherian did a lot of work on stem cell therapy for cardiology, particularly the cardiac failure, particularly the cardiomyopathies. But it had not gone to the stage of human clinical trial. He has done a lot of animal trials. Somebody has to take it to the human clinical trial. So I will be actually talking about the FDA regulations regarding orthobiologics and the future of the cell therapy. So orthobiologics, as by definition, is the regenerative products which are derived from body's own cells and growth factors, which can reverse the multiple pathologies, including the musculoskeletal, which we are going to deal more now. So regarding the legality, all of us should know what is the legal basis for our treatment. So when a patient comes to us, the treatment, either we give drugs to the patient. After we examine the patient and make a diagnosis, we either give a drug or we do a procedure in the operation theater. When we give the drug, the patient goes to the pharmacy, and in the pharmacy, they give the drug to the patient for consuming. That drug has to be approved by the drug controller. So all the drugs which are available in the pharmacy are all approved by the drug controller, and there will be a date of approval. If you examine, all these drugs will have a letter with a date of approval from the DCGI. And once the approval is given, within few years after all of us started using it, thousands of doctors using it, then the guidelines are formed 3 years, 4 years, 5 years later, where they will give the guidelines to give to which age group, which stage of the disease. So all those guidelines come 4-5 years later after the date of approval. So this you should know, what is guidelines, when it comes, what is approval, whether we can use drugs which are approved without guidelines. So in the initial 4-5 years, all of us will be using it without guidelines. Suppose when we do a procedure like skin graft or bone graft, what we do in the operation theater, there is no need for DCGI approval. So there is no regulatory body inside the operation theater. It is between the doctor, surgeon, and the patient. So any procedure like skin graft, bone graft, so muscle transfer, tendon transfer, nerve transfer, whatever we do, that we need not ask anybody. It is our priority. So no date of approval for this. Suppose, so is there any date of approval for skin grafting? Is there any date of approval for bone grafting? So there is no date of approval for any of these procedures because there is no authority who can give approval for procedures. So this is again the explanation. So the particular drug tirzepatide was approved for both diabetes as well as weight reduction in May 2022. But on the American Association, Diabetic Association, included it in the guidelines only in January 2025. So it took 3 years for a drug which was approved. It was used by many doctors. It was used all over the world without guidelines, and only after 3 years, so guidelines came. So all of us should know that the difference between approval and the guidelines. So autologous treatment, we give blood products. No, nowadays we do platelet-rich plasma. We do they do eye drops, serum eye drops, conditioned serum. So all those blood products, if we use a kit for preparing the CPRP, then that kit needs to be approved. The processing kit has to be approved by the DCGA. Similarly, the cell processing kit, suppose we are using the bone marrow BMAC or we are using microfat, nanofat, the kit with which we are preparing, that kit has to be approved by the DCGA, not the condition, whether we are using it for osteoarthritis or whether we are using it for a partial tear of a ligament or anything. The diagnosis or the disease is not approved, but only the kit needs approval. Whereas the scaffold, no, suppose we are using skin graft, bone graft, tendon, as I said, momentum, all these things, there is no need for approval from anybody. Similarly, cells, instead of autologous, then when we take the cells and then send it to a company for culture, then also the company needs to get their GMP approved. For example, for AVN, avascular necrosis head of femur, we use cultured osteoblasts. You take a biopsy and send it to the company called Regrow. So they will grow the biopsy, whatever we have taken, and then prepare 48 million osteoblasts. And then after 3 weeks, they will send it to us, which we can inject into the affected area. So that's called OSGROW. Similarly, for cartilage defects, you take a biopsy from non-articular area and send it to the company. They will culture and send it back. So these are all cultured autologous cells. So for all these things, similarly for stricture urethra, if you send the oral mucosa to the company, they will make a culture of the mucosal cells, and that can be injected for stricture urethra. So these are all approved, prepared from a GMP center which is approved. So these are also autologous, but the company which cultures them has to get their GMP approved. So this is again some of the PRP kits which we were able to find in the website. Suppose if you want to do PRP, so you go to the DCGA website, and then there are medical devices, and then in the medical devices section, you look for kits for platelet-rich plasma. So whatever kit is there, they are all approved. So this is what we took from the DCGA website. So similarly for autologous cells, as I said, when we use BMAC, so this is the kit which was approved by from the span, and all these approvals are only for 3 years. So we have to verify whether those companies have extended their approval. So that we have to make sure. Then coming to the allogenic products, similarly, like fibrin glue, where the ready-made fibrin glue is available. This is not autologous product, this is allogenic product. So this is entirely approved by the drug controller. So it is like any drug. Similarly, scaffold, like when we use the skin bank, cadaver skin bank, now they are using it for burns cases. Sperm bank they use for infertility. Bone bank, eye bank. So all these need the DCGA approval, regulator approval for the banking facility. So the DCGA and the local regulator will come and inspect the eye bank, bone bank, and then verify whether they are following the norms. Similarly, when we use allogenic cultured cells, so these are all the allogenic cultured mesenchymal stem cell products which are available in India, and they have all been approved by Government of India, DCGI. So STEM1 was approved in 2022. Regenasip was actually approved in 2017, but it is available only since 2020. So, and these cultured stem cells condition medium products for hair regeneration, skin regeneration. There are condition medium products which are also approved from 2022. So these are some of the approved products. So I am just giving you a list of approved products. Tomorrow when somebody asks you, are you doing approved therapy, then you should be able to tell them all these facts, that Indian government is supporting stem cell therapy, Indian government is already approving a lot of stem cell therapies. It started in 2017, and now in these 7, 8 years, there are already 7 products which are approved. So, and 2 or 3 more products are being in phase 2, like the one in Delhi, New Delhi, AIMS for the Crohn's disease, fistula in, Similarly, one for diabetic ulcer is already completed. For disc disease also, there is a phase 1 or phase 2 trial going on. So all these approvals will come within another 2, 3 years. So Indian government is very, very proactive, and there is no other country. Here I have mentioned India is the only country in the world with 7 approved stem cell. When we say stem cell therapies, we are talking about the mesenchymal stem cell therapies. We are not talking about hematopoietic. We are talking about the mesenchymal stem cell therapies. So as I said, for osteoarthritis, stem 1 since 2022. For Berger's disease, though it is approved 17, it is available from 2021 for Berger's as well as for diabetes. Similarly, for skin, hair regeneration, under eye dark circles, these products, the condition medium products, condition medium derived from allogenic bone marrow stem cells, they are approved. Similarly, Relicel was approved in 2014. So it is autologous limbal stem cell. So you take a limbal biopsy, send it to the company, they will culture and send it back to you for curing corneal blindness. So apart from that, gene therapy, Zolgensma is approved by the US FDA, and it is given in India to children with spinal muscular atrophy. It is a very costly therapy, costs around 20 crores. And immune cell therapy for cancer. For example, for blood cancer, CAR T cell therapy is available. It is approved in India since October 2023. So these approvals you should know, and you will definitely be bombarded by people asking for proof. So you should be able to, you can take pictures of these slides and then have it with you so that you can show it to somebody and then spread the awareness so that many people can avail the use of these stem cells. So as I said, this is the company Regrow, where they have 3 products: Osgrow, Cartigrow, Urigrow. All these 3 are approved. So Osgrow costs around 1.8 lakhs. So for avascular necrosis, Cartigrow again for cartilage defect, Urigrow for stricture urethra. Up to 4 centimeters of stricture, this will work. Urigrow will work. You have to take a biopsy from oral mucosa, send it to the company. Within 3 weeks, they will send it back to you after culturing, which you can inject into the strictured area, around the stricture area, where there will be reversal of fibrosis, and the patient will be able to pass urine. So remove the stricture, restore the urethra function, and natural preservation of urethra. This is the outcome of urine. This is treatment of the regenerative medicine application in urology. We are mostly talking about orthopedics, but there are other specialties also where this regenerative medicine is useful. I am just posting these approval letters with the date. Again, for many people, doubters who have got doubt whether India it is approved in India. So just I took it from the website, from the DCGI website. You can also look into the DCGI website and download this certificate showing the approvals. So worldwide, what are all the other stem cell therapies approved on which are all the countries? Japan, they have approved what I said for Crohn's disease, for multiple fistula in they have already approved it. In India, it is in phase 2, but in Japan, it has completed phase 3 and now it is already available. Similarly, for GVHD, graft versus host disease, it is approved already in Japan. And Japan is the only country where there is an approval for a neuro condition. The only neuro condition which is approved throughout the world is for Parkinsonism, and that too in Japan and Korea it is approved, where they take patients' own stem cells, autologous. They take from the fat, culture it, 200, and then they give 5 doses. 5 doses, 200 million cells, 150 million cells given intravenous, and 50 million given intrathecal every month for 5 months. So that's the treatment for Parkinson's disease using autologous stem cells. So the Korea and Japan, the manufacturing is done at Japan, and both these countries use that. Similarly, in Europe, this alloficel is used for Crohn's disease, like how in Japan. And similarly, Holocar is the stem cell therapy for cornea, like how in India we do limbal stem cell therapy. They have got Holoclar, which is for cornea. And in USA is the last country to join because they joined only in December 2024. This is their first approval in for bone marrow derived stem cell therapy for steroid resistant graft versus host disease. So this is one of the fatal diseases. So when somebody has a bone marrow transplant, and then if there is the rejection, and if there is graft versus host disease, the only option is giving steroids and other immunosuppressant. If that doesn't work, the patient will die. There is nothing else to offer. So now they are giving stem cell therapy, which can restore some of the patients who are fatally affected by steroid resistant GVHD. So STEM 1, as I said, this is the product available in India. It is not available anywhere in the world. Any Indian orthopedic surgeon who has got their case of phase 2 or stage 2 or stage 3 osteoarthritis, if the patient wants stem cell therapy, you can order it from your lab, from your pharmacy. It will go to the manufacturing place, which is Manipal, through Alchem. Alchem is their distributor. So from your pharmacy, order will go, and then within 3 days, you will get this STEM 1 in a liquid nitrogen tank. They will send it to your address, your hospital. You have to just take the, you have to mix it with plasma light, 1 ml, and then the 2 ml you have to inject into the knee joint. It's an intra-articular injection. You have to thaw it for 30 minutes. After taking it out from the cool container, thaw it, and then inject it intra-articular. So it's a single intra-articular injection, and the initial results, they showed at least 1 year pain and stiffness reduction, and then it maintains the quality of the and volume of the cartilage for over 1 year. All of us know that the cartilage volume decreases as the years go by, but in only in stem cell therapy you can see that the cartilage volume can increase in a certain age group when the regenerative capacity is good. When we treat early, then we can see cartilage volume increase, regeneration of cartilage. So minimal side effects. So recommended for grade 2 and grade 3 osteoarthritis. So this is taken from, how do they make these stem cells? They take it from 3 people. It is a bone marrow aspirate from 3 young adults, and then it is pooled. All the 3 the members stem cells are pooled, and then it is cultured, and from that culture you can make 1 million doses, and that can be preserved in a lab and sent according to the need to every doctor anywhere in India within 2-3 days through a cold chain. So other indications, as I said, other indications like osteoarthritis, it is the diabetic foot ulcer and perianal fistula. These are all soon it will be coming, another 1 years. So this is, I will show some of our cases. You can see here it is a narrowing of the joint space before and after injection in a 55 years old lady, which sustained for nearly 6 years with a single dose. So here also you can see the not only the joint volume, cartilage volume, but also the irregularity of the articular margin. You can see that the articular margin irregularity is also, it has restored. Subchondral bone, the quality of the subchondral bone is restored, and you can see the osteophytes can also reduce or disappear. All that is because the stem cells reverse the pathology. There is no drug to reverse any pathology. In allopathic medicine, we have never reversed any disease. We only give painkiller, we only give symptomatic treatment, or we give substitutory treatment. If insulin is not there, we will give insulin. If dopamine is not there, we will give dopamine. We have never made the body produce insulin again or body produce dopamine again. So our treatment is either painkiller or only substituting. So make them from outside. We have never done anything regenerative in our allopathic practice all these years. Now it is the chance for us to learn this and make our body produce all these again and regenerate. So all the bad name allopathic doctors had all these years is because we failed to utilize the regenerative capacity. We depended upon the drug companies. So we are happily sitting in our clinic. The drug company will work on some drug, and then they will bring a drug. Some 10th standard fellow or one BSc fellow will come to our chamber. He will say, sir, this product is new, and these are the highlights. Then we start prescribing. So this should not be the case anymore. So we are not dependent on drug companies to help us to treat our patients. We don't need the help of anybody if we are capable of using our own body's regenerative capacity. So how are we going to do that? That is this medicine of regenerative medicine, this course. And so I am happy that all of you have joined, and you are not going to be like any other doctor sitting in their OP waiting for the pharmaceutical company or the instrument company to give you some instrument which we will use to do a joint replacement. So you should not be just a consumer of drugs or consumer of instruments. You should be able to treat the patient using the biology which you learnt in all your 10 years of MBBS and post graduation. So here also you can see the increase in the cartilage volume. You can see that. So we are going to take not only these X-rays. So here we have shown how long the effect lasts. Suppose you give one injection, how long does the effect last for the patient? So here you can see it has lasted for 4 years. And if the patient BMI is normal, and if the patient is regularly doing exercise, then with single dose of bone marrow concentrate, you can have minimum 4 to 5 years of sustained relief. And if at all after some time, if there is a pain, you can always repeat the procedure after 4 years, 5 years, 6 years for another 4, 5 years of relief. So we are not only showing X-rays. So X-rays are very easy to take. So we have shown, but we can also show in the MRI. So the cartogram and this MRI can show a new formation of the cartilage, good quality cartilage. So here you can see pre-op and post-op, you can see good quality of the cartilage. After this is taken, it's not my case, it is taken from the literature, from the net. So this is adipose-derived stem cells. It is showing the good amount of cartilage formation. So again, these are all again increase in the cartilage height. So here you can see from 4.7 to 5.89 increase in the cartilage height. So again, not only cartilage, but also there are internal structures like the menisci, the cruciate ligaments, the collateral ligaments. They are also injured. They are also affected in osteoarthritis. So we are not only regenerating the cartilage, we are also healing tear, partial tear. If there is a partial tear, see, you can see 1 year after the PRP treatment, you can see the very good regeneration of the ACL. So here you can see the T2 image. You can see very good regeneration of the ACL. So we are regenerating not only the cartilage, but all the structures inside the joint. So this is a computer generated histogram. So the histogram is a computer AI tool which helps in showing us whether the collagen formation is strong or not. If you have a strong collagen formation, then there will be a shift to left. So this shift to left indicates that the collagen, quality of collagen, you can see the quality of collagen here before and after. Here also you can see the quality of collagen. When the quality of collagen improves, there is a shift in the left. So this, instead of taking a biopsy, even without taking a biopsy nowadays, with the help of the investigations, we can show that the cartilage is not only restored, but it also quantitatively and qualitatively it has improved. So this is again BMAC. You can see the quantity of the quality of the regeneration. So again, some of the proofs. So some of them I have taken from the literature. So here also you can see it is the medial meniscal lesions, which after 6 months after the injection, you can see there is a healing. It is just PRP only. This is using only the autologous PRP, pre and post. So all of you doing these procedures, you should collect the pre and the post pictures and then present it in our conferences so that we can build the evidence. So now after osteoarthritis, now we come to critical limb ischemia. All of us know that diabetic foot ulcer is a very, very difficult condition to treat. Why it is difficult condition? Because of endothelial dysfunction. So many reasons. There are so many molecular and pathological aspects which are responsible for these diabetic ulcers. That is we cannot address all these pathologies with one treatment. That is why 100 ways of treating diabetic foot ulcer. It is an interesting lecture by Dr. Ravi Kumar Chitoria from JIPMER. So why are there 100 ways of treating one condition? Because every treatment is not successful. If there is one successful treatment, why should we go for 100 ways? So that shows that for diabetic ulcer, whatever treatment we are doing now, it's not 100% successful. So that is why this stem cell therapy has come as a rescuer. So this is approved stem cell therapy. We saw this previously. This is called Regenasip. This is also derived from allogenic bone marrow stem cells cultured. And any doctor, if you prescribe, you will get it in 3 days and you can inject into the limb of the affected person to get collateral circulation, new blood vessel formation, that is angiogenesis. So here you can see this is the study which was submitted for the critical limb ischemia by Dr. Pawan Kumar Gupta and the others, so that the FDA gave the approval. So this is what they have shown, improvement in the ankle pressure and the ankle brachial index. So there should be, if at all there is good restoration of the blood flow, good restoration of the collateral circulation, so then the pain will disappear, the ischemic pain will disappear, ankle pressure, toe pressure will improve, as well as the ankle brachial index will also improve if there is regeneration. So this is what they had shown with the MR angiogram, the new blood vessel formation in areas which were affected, new collateral blood vessels. So we have also shown in our case, so this is our case of a 42 years old male who was a smoker with a claudication and non-healing ulcer. Distal pulses not felt, and the vascular surgeon said, I cannot do anything, amputate. So this was before injection. Below the ankle, below the lower third, you can see there is very little flow. And this is after injection. You can see that the collaterals have formed. The main blood vessel will not open, but the collaterals will open and the limb will be saved from amputation. So this person we injected in 2017 and now it is 8 years. We have not amputated for him. So this is another case, 65 years old diabetic as well as smoker, whose CT angiogram showed there was block and they have done a bypass. See, the popliteal artery, this side is okay, but this side the popliteal is blocked. So they have done a bypass. So this is the bypass which they did 4 or 5 years back, but that also now got thrombosed. After 4 years, the bypass also got thrombosed. Now there is no flow either through this or through the bypass. So that is the patient again, he came with severe pain and ulcer. And after our injection, you can see that there is collateral formation. They tried femur, they also tried profundoplasty in this patient, but that also did not work. So it was failure of all the vascular procedures. Endovascular procedure failed, open bypass failed. So it is in such cases where everything fails, then it is the chance for the stem cells to show the success. So these are some of our cases. You can see very gross ulcers which have been healed without any surgery, without any skin graft. It is only injection of stem cells. So 3D printing is also upcoming. One of the upcoming specialties Now you can 3D print skin using the stem cells. So this is a Korean company machine which was approved by the Indian FDA, and Alchem got the franchisee. So Rocket is the Korean company. So this is a tabletop machine which you can carry inside the operation theater, and it contains two. These are the two cartridges. In one cartridge, you have to put the patient's own stem cells. In another cartridge, you have to put the fibrin material which is supplied by the supplier, Rocket Healthcare. So how is it done? It is on the spot 3D skinting, 3D printing using two bioinks. One patient's own, one is prepared. So this is the ulcer which did not heal for a long time. So we had done a 3D printing for this area, and this was after 1 month when the patient came for dressing. So how we did that? So as I showed that 3D print, you have to take a photo. You have to take a photo of this ulcer, and once you take a photo of this ulcer, once you take a photo of this ulcer, you can send that photo to the 3D printer machine by Bluetooth. Once the machine receives the picture of the ulcer, depending upon the depth, the length, the borders of the ulcer, so it will make a print. This it will 3D print within 30 minutes. What we have to do is we have to take patient's stem cells from the abdomen. You have to do a lipoaspiration from the patient's abdomen, and then that is used as a one ink. That is the stem cells contained in the fat. So that is put into one of the cartridges, and the other cartridge will have, this is the cartridge, no, I told. So in one cartridge, you put the fat stem cells taken from patient's abdomen, liposuction. You take the help of your plastic surgeon, and they can do liposuction, and then you can, with kits, you can convert them into fat containing stem cells, and then use it as a bioink. The other bioink is supplied by the company which contains fibrin. And then within 30 minutes, the 3D printer will print according to the size and shape of the ulcer and depth. So that you have to just keep it on the ulcer site and then do a dressing. And then it goes on to heal. So this is limbal stem cell therapy. As I told you, whenever there is a severe acid injury or alkali injury to one of the eyes, if the other eye is normal, then ophthalmologists found that limbus. So this is the limbus. Limbus is the area where the cornea and the sclera they meet. So in limbus, you have stem cells. There are stem cells in the limbus. So what they did, they took a biopsy. It's a small piece from 3 o'clock, 6 o'clock, 9 o'clock, 12 o'clock, and then they will keep it in the affected eye, 3 o'clock, 6 o'clock, 9 o'clock, 12 o'clock. So this bit of limbal stem cells from the limbus normal eye, if it is kept on the other affected eye, within 4 months, 5 months, from 0% vision, you can see the patient will have 40%, 50% vision. So this is restoring the vision from 0% to a minimum 30 to 50%. This is done in every tertiary care eye hospital like Aravind Eye Hospital, Madurai, Shankara Nethralaya, Chennai, Narayana Nethralaya, LV Prasad Institute, Egmore Eye Hospital, so AIMS, Delhi. Everywhere they are doing this stem cell therapy called limbal stem cell therapy. And India is the only country where huge numbers of corneal blindness or reversed patients are getting back vision with stem cell therapy, limbal stem cell therapy. So now you have seen who are all the specialists today who are using PRP, and tomorrow they will be upgrading themselves to use stem cells. So PRP is the first step. If you learn PRP, then next you can learn stem cells. So dermatologist, orthopedic, sports physician, plastic surgeon, diabetologist, vascular surgeon, gynecologist, we are doing a lot of cases for infertility, for thin endometrium, similarly for ovary regeneration. So dental surgeons are using a lot of regenerative procedures. So we have done for submucous fibrosis, osteoradionecrosis. Lot of conditions we have treated with stem cell therapy and principles of regenerative medicine. So in our conferences, we should involve all these people and we can learn from them. So you know how the ophthalmologist learned to do this limbal stem cell therapy. Do you know whom they learned it from? They learned it from the plastic surgeon. So plastic surgeon take a skin graft and then they divide it into multiple pieces. So that is called meek grafting. So this ophthal surgeon who was treating these corneal ulcers, who was fed up because he could not restore the vision, when he met a plastic surgeon, he learned that this breaking down of the big chunk of tissue into smaller chunks called meek skin grafting. Similar technique he adopted, and then these four pieces now they are multiplying into four is divide each piece is divided into four pieces. So now they have 16 pieces which they place over the cornea either with amniotic membrane or fibrin glue, and then within 3 months, 4 months, they get back the vision. So who did he learn from? He learned it from a plastic surgeon. So that is why all of us should talk to other specialties. So for completion, I am saying this gene therapy for spinal muscular atrophy, it is 16 crores, 21 crores with tax, without tax 16 crores. Already a few children in India have received this Zolgensma. And then CAR T cell therapy, this is you take the you take the T cells from the affected cancer patient. So you collect the cancer patient's T cells are collected and then that is transfected with the antibodies which will destroy the antigens, cancer antigens. So they will have the cancer antigens and their matching antibody will be integrated into the T cell so that it can fight the cancer cell and kill it. So today we are treating osteosarcoma with CAR T cells. Already it is approved for B cell leukemias and we can improve the cure rate of cancers. And we need specific genetic engineering has to be done in the lab, which is very small numbers are now being combined. And when these combined cells, CAR T cells are combined with checkpoint inhibitor drugs, then the success rate becomes more. So finally, I just want to show that we have regenerated every tissue in the body. If you are a dermatologist, we can regenerate the hair, we can regenerate the skin. If you are a gynecologist, we can regenerate the endometrium, we can regenerate the ovary. So whichever specialty you are, we are capable of doing this in your specialty. So regeneration is possible in your specialty. So here we did the PRP for this boy. You can see after four episodes, 4 injections. So this is ulcer healing, skin regeneration, that is hair regeneration, skin regeneration. This is endometrial regeneration with increase in the vascularity. So not only the thickness of the endometrium, but also the vascularity will improve. Angiogenesis will happen. Similarly, this is for oligospermia. So less number of sperms. After injection stem cell therapy, increased number of stem cells, increased number of the sperms, not only number but also motility. Similarly, oral mucosa, you can see this is oral submucous fibrosis. Patient cannot open the mouth fully. He is taking Panprag and then he is developing fibrosis. So this is the fibrosis histopathology. You take a biopsy from the cheek, it is how it is so bad. These are all inflammatory cells. This is irregular matted collagen. But after stem cell therapy, you can see the wavy pattern. No? This wavy pattern is normal collagen. Normal collagen is always wavy, whereas this fibrosed collagen, this is destroyed collagen. It is matted appearance. So from here, after stem cell therapy, you can get back normal collagen. The patient can not only open but also put out his tongue. You ask him to put out, he cannot put out beyond this. But after injection, you can see he is able to put it out. And the salivation will also improve after this. So this already I have shown you. This is vascular regeneration, blood vessel regeneration. This is neural regeneration. We have treated some cases of cerebral palsy, autism, Parkinsonism, Alzheimer's disease, stroke, traumatic brain injury. So many diseases, neural diseases are also we can treat with stem cell therapy. The neurologists are not interested. They are actually, I am very happy that there is a physical medicine people who are involved in this specialty, because orthopedic surgeons and the neurologists, they will send the person. Suppose a patient comes with cerebral palsy, very bad cerebral palsy. If there is any operable condition, we will operate. Suppose there is a TA tightening. If there is equinus deformity, we will do the surgery and then we will send it to the PMR for further recovery. If the patient again and again comes to the orthopedic surgeon, if the patient again and again goes to the neurologist, to the pediatrician, sir, when will my neuro problem become normal? Can I become normal? So similarly, Parkinson patient, an Alzheimer patient, if they again and again go and ask the neuro, they will get irritated. The orthopedic surgeon or the neuro, they get irritated. They will just blast the patient, tell you, I have already told you there is no scope for you. Neuro will never regenerate. You only go to physiotherapy, you go do physiotherapy. Whatever you get, that's all you can get. So this is the attitude. And the final rescuer for them is the PMR people. So it is the PMR people who strive every day to bring improvement in the situation of such hopeless patients. So you can see so many spinal cord injury patients after 1 year, 2 years, when there is no recovery, no ortho doctor, no neurologist, no neurosurgeon would like to see them after 1 year or 2 years, because there is no hope from their side. But they continue to go to the PMR because they every day they work on the patient and show some improvement. But now with the advent of stem cell therapy, not only the physiotherapy, but we can regenerate some of the neural elements, and then we can get much more better results. So there is hope. When somebody says there is no regeneration possibility for in neuro, don't believe. Soon we will get that. So this is the this is the vitiligo which I have shown here. You can see we have taken stem cells from patients who own hair follicle. We took from his occipital region, we took 30 hair follicles, and then we took the stem cells and melanocytes and then injected into the periphery. We did not inject into the eyelid, because usually eyelid it will go for severe edema if we inject. So we avoided the eyelid, but you can see even when we did not inject in the eyelid, when we injected only in the periphery, the pigments are started to moving to the eyelid. So this is regeneration of melanocyte regeneration. So this is post irradiation skin fibrosis. So here you can see dry skin. This is the scar of surgery for cancer, oral cancer. They have done mandible, they have cut the mandible and they have gone and removed the tongue with the cancer. So, and then given irradiation, and you can see horrible skin which is dry, fibrous. But after injection of stem cells, you can see it has not only restored the quality of the skin, but also the mucus secretion, the sebaceous secretion, and the sweat glands. So that brings us to the end of the talk. So it's not, you should know about the regulations. You should know about the regulations, and you should know about the future of stem cell therapy. So thank you, Madan, for this opportunity.
Thank you, sir.
Any
Thanks a
questions?
lot for the
Yeah.
wonderful lecture. So, fellows, if you have any doubts regarding this lecture, you feel free to ask doubts to Ravi sir now.
Yeah, so my question is, sir, like in DCA's approvals, so you mentioned only bone marrow derived stem cells.
Correct.
What about ABPOs, sir, or the PRPs, whatever?
So PRP only you need the kit approval. You don't need any disease approval. If you use an approved kit, then you can do it.
Okay, sir.
You have to verify the website. You go to the website and verify from DCG website whether the kit which you are getting, you ask the company to show the DCG approval letter.
Okay,
If they show, then you can use the kit.
thanks.
Sir, hello, sir. I just have a clarification.
Yeah.
about the stem one allogenic stem cells.
Yeah.
Do they provide us the cross compatibility test they do
So
for?
no, for mesenchymal stem cells, there is no need for cross compatibility because mesenchymal stem cells don't carry HLA surface antigen. It is only for hematopoietic stem cells that you need. So this is like platelet. There are three cells in the body which don't need the compatibility. One is platelet. Number two is NK cell, natural killer cells. Number three is mesenchymal stem cells. All these three cells don't have HLA surface antigen. You can give from one person to another person without matching.
Thank you so much, sir. And what is the approximate cost, sir?
1.25 lakhs for osteoarthritis and 1.6 lakhs for critical limb ischemia.
Thank you so much, sir.
Akash, that 1.25 lakh is for one single knee.
Single
Yes,
knee.
just for clarification purpose.
25 million cells in one bottle.
Yes, sir.
Yeah, 25 million cells for 1,25,000.
Yes.
Dr. Shelley, you were asking some questions. Dr.
Yes,
Shelley?
yes. I'm so sorry. Hi, Dr. Milan. Thank you,
Yeah.
Dr. Ravi. It's a wonderful lecture. I'm so delighted we are having you in here. Thank you, Dr. Madan. So my queries are might be sound silly, but my query is as we already discussed with so many type of therapy, so many diseases we are using the stem cells. My
Mm.
question is the exact like place where we putting the stem cells, like in an ulcer, as you already told that it's at the local, it increases the local vascularity, so that
Yes.
heals. In case if we plan to put or use the stem cell in neuroregenerative, like diabetic neuropathy or other neurodegenerative issues. At the what point or what site we are using exactly? I want to clarify that
Yeah.
part.
So
That's
that
another
will
question.
all be taught in the further course of this course. So for each disease, for to reach each organ, there are multiple routes. Suppose you want to, for the ulcer, diabetic ulcer, if the vascularity is so bad, if there are multiple blocks, we have to give along the course of the vessels. We
Mm-hmm.
have to have a Doppler done and then see the course of the vessel. And then along the course of the vessel, we can give every 2 centimeters, we have to give 0.5 to 1 ml. So it is multiple
Okay.
injections along the course of the artery, perivascular or into the intramuscular. Then around the ulcer also. So for such patients, you have to deliver at multiple points. So similarly for osteoarthritis, it is not only into the joint, but subchondral bone, if it is affected, you have to inject the stem cells into the subchondral bone also. Similarly for neuro, it has to be intrathecal. I showed no for Parkinsonism. Approved therapy in Japan and Korea is two routes. One is intrathecal, 50 million, and the other 150 million has to be given intravenous. We can also
Oh,
give
okay.
intranasal to reach the olfactory mucosa. So
That's
that
good.
is also one
Okay.
route where you can deliver, and then the stem cells can easily reach the brain, crossing the
Hmm.
cribriform plate. So this is what we will be teaching you this year along. So you will be
Okay.
learning in which disease, how to do, what is the
Okay.
dose, all those things.
Okay. So thank you so much. Thank you,
Yeah,
sir.
yeah.
More
Sir, Dr.
doubts?
Soveed Dhakad here. Thank you for such a wonderful lecture. Sir, I wanted to know, you already talked about allogenic bone marrow approvals
Yeah.
by DCGA. Sir, what about autogenic?
No, autologous we can do that. I told no, there is no need for approval. Suppose only the kits need approval. Suppose if you are using a kit for preparing the bone marrow, you have to only make sure that kit is approved by the DCGI. You are
So
good.
that
You can do it for osteoarthritis. You can take patient's own bone marrow and inject it for avascular necrosis. You can inject it for ACL tear. Suppose you are doing ACL repair. And then you can augment it with patient's own bone marrow stem cells. So only the indications are not approved by the drug controller. You
okay.
can use it for any indication. Only the kit which you are going to use, you have to make sure whether it is approved or not.
So, in your slides, there was a company called BioPro, which you showed it is a DCGI approved,
Yeah, yeah.
CDSCO approved.
Yes.
So we can use that for bone marrow also.
Yes, yes. So you have to make sure, you have to see the leaflet. You find out whether they have made any special thing for bone marrow. So whichever you decide, you get the literature, you get the things verified, and then you can use.
Okay, sir.
We
Thank
are
you, sir.
we are not recommending any kit. So because there are multiple kits, no. So our job is not to recommend any particular kit. So our job is to just show you how to select. You can select the kit and then you ask the relevant questions to the company and then get your things. Then you can, if there is any doubt, you can ask us.
Okay. Thank you, sir.
Sir, I have a follow-up question on the last point.
Yeah.
May I? Yeah, for combination therapies like for osteoarthritis, SVF along with BMAC, are the regulatory requirements the same as that for single component products?
No, you can combine. You can always combine PRP with stem cells, bone marrow, or with fat. So with the proper kit, you can combine both. Actually, we did both in that 3D printing. The 3D printer case had a severe block of the blood vessels. So what we did is we took his autologous bone marrow and then injected it for the vessel. And then we took his fat from the abdomen and then we used it for 3D printing of the ulcer, 3D print for the ulcer. So you can combine. There is nothing wrong in combining autologous. You can combine autologous and allogenic. So you now
As
know.
long as the kits are independently approved, it's all right.
Yes, correct. Now, because there are a lot of kits, there are some of them are good, some of them are very good, some of them are very bad. So, and also every patient, if he is a young patient, his platelets are good. If he's a very old patient, his platelets, they don't produce enough growth factors. So to nullify all these variabilities, you want a consistent growth factor. So what we are now doing is we are making this PRP in powder form. So lyophilized PRP. So we will soon be getting these approvals, and each bottle which we get this lyophilized PRP will have a specific known amount of growth factors. What is the quantity of VEGF in 1 milligram of that lyophilized PRP? What is the quantity of FGF? What is the quantity? So all that will be in the label. So that is one way to standardize. Otherwise, there are hundreds of kits. You don't know which is the best kit, which is not the good kit. So we are trying to standardize it some way. And one of that ways is bringing out the powder form.
Thank you, sir.
Yeah.
Sir, I have a two-part doubt, sir.
Yeah.
The first thing is, in case if I'm planning to contribute in developing a device or a kit, how to go about it. And the second part is, there are many ethical considerations before we start on a new trial.
Yes.
So in case if there is animal approved study for a particular drug or a therapy,
Yeah.
how can we, what is the line roadmap which we need to follow to get to the guidelines or approval?
So that will be a separate talk, doctor, because it's a long process.
Okay.
So I think we will have one regulatory consultant talking about that. So we
Yes,
can
sir.
do.
We have a separate talk on this.
Correct.
Okay.
So it is possible.
Thank you.
Yeah. Bye.
Thank you, sir. Fellows, now let's start selecting the topics which we have planned to submit to the university. From past 2 days, I mean, few guys have started sending the topics on the groups. So now let's confirm those who have sent, and the rest of the candidates, please do send within this week, so that we'll try to pull it up and we'll start the work and we'll allot the mentors and we can go ahead. So the first one who has sent us Dr. Sunil Malhotra. Is sir there around? Sunil sir? Okay, let me go on to the second one. Dr. Saket have sent enhanced co-decompression with bone marrow aspirate concentrate injection for AVN of hip, a bimodal approach for optimized healing and joint preservation, a retrospective study. Saket, do you have ethical approval for this?
Yes, sir. Yes, we have been doing this under ethical approval. So that's why I've selected a retrospective study, and we'll be adding few patients.
Okay, how many cases have you done, Saket?
Sir, since I've joined the institute, it's almost I have a sample of around 30 patients till now.
So do you want to wait for another 6
So-
months to do, or do you want to start working on the paper right now?
I'm starting. I'll start working on it, sir. And if there are any few cases that that'll be coming to us, then I'll be including it in the study.
Okay. Then, Saket, I think it's good to go about it. And what is that bimodal approach?
Sir, so bimodal approach is where we inject the bone marrow aspirate concentrate not only into the decompressed area, but also we perform a hip arthrogram and inject the bone marrow aspirate concentrate into the hip joint as well. So
Okay.
we are selecting cases till stage 2B of the standard Ficatalet staging. So wherein the head shape is maintained, and also we are supplying the joint as well, not only the core decompressed area.
Okay. I think it's good to go. Saket will be allotting mentors soon. Those mentors will be among me, Dr. Arul, Dr. Naveen, or Dr. Satish. And we have research coordinators, Dr. Sangeeta and Dr. Swaminathan, who will be helping you guys in how to go ahead with the paper writing, all those things.
Okay, sir.
Now coming to Dr. Anju Sangeet, she has sent a paper of interest as molecular characterization of PRP or PRF.
Sir, am I audible, sir?
Yeah, you are very much audible. So you have
Uh,
given the topic of molecular characterization of PRP or PRF.
PRF. Sir, what?
My only thing is, please stick on to one thing.
Yes, sir. Actually, I want to like since each this platelets are the activated platelets will be secreting many of the growth factors and cytokines, no, sir. So each has got a specific mechanism of action. So I want to concentrate in one of that. Either like I don't
Then
know
we'll
whether it's
go ahead
possible
with
or not.
PRF because PRF, no much studies are there, no much papers are there.
Okay, sir.
So I think it
Okay,
will be
sir.
good to go if we take PRF.
PRF. Okay, sir. So
We'll
what
try
about
to plan a
BMAC or
proposal.
BMAC, SVF, any like I haven't seen studies on that also
No,
much.
BMAC SPF characterization also is not there in the
Yes, sir.
literature. We can try to do. First, let's finish off this PRF. Then, if time
Okay, sir.
permits, then we can use it.
Okay, sir.
Okay. Then, Akash,
Yes, sir.
you have sent photobiomodulation following PRP and orthobiologic therapy, a synergistic approach in regenerative orthopedics.
Yes, sir.
I think your topic should be photobiomodulation following PRP therapy,
Okay, sir. Yeah.
a synergistic approach in regenerative orthopedics. Are you going to do a review article, or how you are going to do ahead?
Sir, I'm planning to do a review article.
Is it a systematic review or a scoping review or a narrative review?
Sir, I haven't decided. I was looking for your guidance regarding it.
I think it's good if you have a lot of papers for systematic review. If not, we can go ahead with scoping review.
Okay, sir.
I think it will be good to go.
Okay, sir.
And next one is Dr. Soveet Dakat. He has sent a case report increase in blood flow by lumbar neurectomy and BMAC in patient with Buerger's disease with failed endovascular bypass. I think Soveet, this is the one which you discussed yesterday to me, right?
Yes, sir.
This is the one. Okay, let's do that as a report, not a problem. One or I think Dr. Manik Rana has texted me regarding the selection of topic, and rest others have not even decided anything. So if you guys want any support in the form of topics like clinical, or how Dr. Anju has taken like preclinical, or sorry, she has taken in vitro actually, in vitro or preclinical, if you want some topics for preclinical or some clinical case reports, some reports in the form of very, very rare ones or innovative ones. If you want something like that, we can help you across. But please do message in the group so that we can fix the article at the earliest and we can start working on it. And the next class is also ready. We'll be sending you the 3 monthly schedule. Till now, all the 3 months, the classes have been fixed. At the end of third month, we are supposed to conduct one PRP workshop. So the workshop date, what we have planned is October 4 and 5. October 4 and 5, Saturday, Sunday. Post that we have a lot of Diwali holidays. So many things are coming up. I don't think it's good to go ahead with Diwali. So let's have 2 weeks prior to Diwali. It's October 4 and 5. So we'll be inviting one national faculty to come to our center to talk more on your PRP, platelet products, all those things. And you'll be having a live clinical case and hands-on as well. So this is what we have planned. So in due course of time, we will be sharing some important study materials also in the groups. And there are certain books which you can follow if you want to have a extensive reading. And I think within next class, we should finalize the topics and we have to send it to the university and we have to start working on the same. Is there any doubts?
Sir, I wanted to ask if I can get 50 to 100 cases on degenerative disc disease, but with endoscopic decompression or discectomy along with that. Not never patient is ready to just go for either PRP or BMAC. It is usually always combined with and patients are actually here. Lots of patients go under Ayushman Yojana, and I am doing endoscopic spine cases on that. So it will be possible to publish with that or not?
You can publish that as a second paper, but actually the first your paper should be of regenerative medicine. If it is not on regenerative medicine, definitely our academy will help you in getting it published. The experts are there. You can place their help guidance in your paper and you can publish. But see to that you are getting a right ethics committee approval. That is more important.
Okay, sir.
Ethics committee approval is very important. Without that original study, I won't be accepting to do it.
Okay, sir.
Because it is going to impact on you, institute, mentors, everything. Let's not deviate on it. Let's get the approval. You just apply for an approval. Once you get a lot of endoscopic discectomies, even after finishing this course, if you want to publish, you are very well welcome to use our expertise to publish it. Not a problem.
Okay,
But
sir.
please do apply for ethics approval. But for case reports and the case series up to 6 cases, there is no need to get special approvals and all. You can go ahead.
Okay, sir.
Yes, Saket. Saket, you were asking something?
Sir, is there any thesis protocol or something for the topics that we are going to go ahead, or is it just a publication that we are going to do?
No, you have to do a publication, proper publication. It's good if you go ahead with a retrospective study or a prospective study or whatever it is. In the worst case scenario, you can go ahead with a case report if you are practicing. If you are yet to start your practice, it's good if you can go ahead with a scoping review. If not a systematic review. Systematic review is little difficult for a newbie to start.
So there is no thesis protocol as such?
No thesis protocol. Just
Okay.
prepare your subject and start, because one more thing, getting published in the journals are not very easy. If we are targeting PubMed, Scopus, Web of Science journals, it's not very easy to get published. So start your work at the earliest so that it will get published at the 10th month of your fellowship. Maybe you can get good to go to get your certificates at the end of the 12th month. Else, till you finish, certificate will not be issued by the university. So this is the hard and fast rule in the university to get it published. It's good if you get published and you will be also known in the regenerative medicine community later in life. It will be useful for you to get a lot of contacts. If someone can do something on meniscus, you are more than welcome. Meniscus biologics or augmentation of ligament surgeries, all these things are more welcomeable. So please see to it whether you can do something before the next class. Let's finalize the topic and we'll start working on it.
Thank you, sir. Thank you.
Thank you, dear. Anything else? And here Dr. Satish is there, Dr. Swaminathan is there. These people are very pioneers in systematic reviews and meta-analysis. You can talk to them whether it can be done. They can guide you step by step to do it. And
Okay,
for
sir.
everyone's information, all the classes have been shuffled again. So first 3 months it will be ABPOs, autologous peripheral blood derived orthobiologics, followed by a PRP workshop. The second 3 months will be of bone marrow and other sources of bone marrow, other sources of your bone marrow, other sources of your stem cells, followed by workshop. Third 3 months will be your adipose tissue biologics, followed by SPF workshop. And last will be your miscellaneous and gene therapy, newer upcoming therapies and all in cellular therapies, unproven cellular therapies, all those things, followed by ultrasound workshop. So all these 4 quarters have been divided in that way, and your things will be taken forward. So every month there will be 3 classes, one basic class, one advanced class, and one publication class. The last 2 months we told it to be on publication that has been divided into multiple classes and it can be placed in all the months. So 1 month means 4 weeks. 3 weeks we'll be having class. 1 week small presentation by the fellows. So this week, what will be the exclusive reading apart from these 2 classes? We'll share some PDFs which has been published. We don't have a proper book as such for regenerative medicine. There are a lot of books, but whatever material is found good in the literature, we'll be sharing in the groups. Please go ahead with reading. Any doubts?
Excuse me, sir. Sir,
Yes,
sir, so I'll be, will contact me in 2 days, sir, about this topic.
I'll call you, I'll call you, Anju.
Okay, sir. Okay, sir.
Yeah. Anything else? Don't feel so like it's so difficult to select a topic and all. We are here very well here to guide you. If you guys are really interested to give level 1, level 2 evidence, please do contact Dr. Swaminathan and Dr. Satish. They'll be helping you out doing your systematic reviews. Other things, basic science or any RCTs. RCT is very difficult. You won't have much time to complete an RCT within a year. Otherwise, cohort study, case control study, retrospective study, or case reports, or review article, or scoping reviews, you can contact any 5 of us. We are all here to guide you. Anything else?
No, sir. Thank you.
If you have any doubts, please reach out to any of us in timely manner. And the next class, before next class, we will allot you the mentors. I'll be waiting till Tuesday. If no topic is taken, we will try to allot some review article at least. Later, you can talk to your mentor and you can refine the article topic and you can go ahead with either review article or systematic review or whatever it is. We'll try to figure out within next Monday or Tuesday. I think this is good to go. Later, we can cater and do one-to-one discussions and go ahead. Anything else? Manikrana and Anju, I will call you guys separately. Manikrana has asked for my guidance for the topic selection. Anju, I'll talk to you regarding your topic zone.
Okay, sir. Okay.
And someone has texted me like, I'm into private practice. How can I get the ethics approval? I'll try to help you out. Don't worry. And possibly, please go ahead with original articles or case reports. Don't go behind your review articles much. I want you guys to be known in the research industry as well, that you have done some research in regenerative science. So please go ahead with some good papers. Even narrative review is also good. If your topic is new, narrative review is also good. So if there is no doubt, we can wind up the class and we'll meet in next week. I think our fellowship academic coordinator will send you the next upcoming classes and the next 2 months schedule. Please plan for your October 4 and 5 visit. 4th morning around 9 to 10 o'clock will start. 5th afternoon 3 o'clock we can wind up. So plan accordingly. Plan your flights accordingly. If we wind up at 3 here, it will take 40 minutes to reach airport by metro if you're coming by flight. So plan accordingly, plan your flights after 6 o'clock. It's better. Anything more? Okay, I think it's good to go. Let's leave now and we'll meet in the next week. Thank you. Bye. Bye, everyone.
Thank
Happy
you.
weekend.